Hello, everyone. Welcome to the latest episode of Affected by Meet. I'm delighted today to be joined by Jordan Abdi. He's the MD and founder of U-Ploid, and Hannah Haigh, who most of you will know as the CEO of Meet. Today, we're going to be talking a lot about IVF, which U-Ploid is obviously very involved with. We're going to touch upon around the challenges and the story of growing a startup, getting investment and everything. But as always, just a very conversational chat. But before we start, Jordan, thank you very much for joining us. I just wanted to get an idea really into how you came into this world. You know, what was your journey into the world of IVF really?
Yeah, well, thanks for having me, first of all. Great to be here. I ended up in fertility, really, and IVF by accident. I background trained as a doctor, really with the motivation to improve outcomes for patients in every kind of domain, particularly in areas where there are not great outcomes in current medicine. And through it's a journey unto itself. I ended up in rare disease, working in life sciences, thinking about how do you bring some of these assets to market when you have the compound challenge of, first of all, there's never been done before in some of these orphan indications, and simultaneously dealing in rare disease where, of course, there just aren't many patients. And so it's a very complicated commercial story of how do you make those kind of investment decisions to justify a relatively small population. And I came across IVF purely by chance. I was on a project where we were looking at a new asset, or a rather older asset that was being kind of relaunched in some new markets. And I was just perplexed because infertility, by all accounts, is an orphan indication. There is no treatment. And yet it doesn't suffer from the same challenges that you see in other indications. There's a mass population to treat. And I just ended up down a rabbit hole that, fast forward 3 years or so has led me where I am now. And at U-Ploid, what we're trying to do is actually take on this orphan indication and bring about the very first treatment to help couples who are struggling to conceive and for which there is no other recourse.
Yeah, I think we'll dive into what U-Ploid is doing. I think compared to some of the other industries and areas that we work in at Meet across life sciences, the world of IVF is something that a lot, if not everyone, can relate to. Yeah, either from a personal perspective or from a family, friends. Some of the science is wild that we have to kind of deal with, but IVF is at least very accessible from an understanding point of view. But from your perspective, Jordan, where is IVF now? Like in terms of the state of the treatment, the market, what's available to patients and everything?
IVF is pretty much where it was 3 decades ago. I mean, by and large, very little has changed since 1993. The last major innovation in IVF was something called ICSI, so the administration of sperm into the egg by injection. Huge kind of leap in the field and help support the treatment of multiple causes of male infertility and male subfertility. And then really since then, what we've seen is the gradual optimization of how labs are run, how clinics are run, how we communicate to patients and how we offer treatments to patients. But the foundations of IVF haven't materially changed in that intervening period. And I think unless we see some real innovation come to market, and we are starting to see new companies and new approaches emerge, we're going to be in the same place we are 50 years from now. IVF is 48 years old. It turns 50 in 2028. And it would be a real tragedy if we don't see some material movement in the field, especially given how crazy it would have been in the 70s to do this for the first time. Like IVF itself is kind of a bit crazy. Producing an embryo outside of the body for the very first time in the 70s, huge leap forward. Since then, we've just not maintained that kind of pace.
Yeah, it's obviously not comparable, but it's very much like the moon landings and someone on the moon, isn't it? We did it, and then we're only starting to look at it again. What does that? You said it hasn't kind of moved as much as we would have liked over that period of time. So, what does in your experience and for people who may not know those who have gone through IVF treatment, what does that patient experience look like now?
It obviously varies greatly, both on the cause of the infertility as well as the the age of the patient. So I think younger patients are either going through IVF because they froze their eggs earlier, there may be a fertility preservation journey, maybe there was like an oncology indication that meant some of the tissue had to be preserved. Outcomes there are pretty good in young patients. We're typically looking at fewer than 3 cycles per successful pregnancy, and once you transfer healthy embryos, outcomes are also pretty good. What we've seen change over the last 2 decades are 1, IVF becoming a lot more common, because 2, people are having children later in life. And that barrier, that deferral of having children until later in life, comes with a serious reproductive penalty. Exponentially so. Certainly after 35, you see this exponential decline in outcomes, particularly in female reproductive age, but also male fertility declines with age. It's much more gradual and over a longer period, but it's the same fundamental problem. And you compound those together and you push them into a system that was designed ultimately for younger patients. Outcomes are declining or flat in most places. And patients, particularly when you cross 40, have very fewer options other than maybe looking at egg donors or adoption or other.
Yeah. Hannah, just to get your view on this, I think although people speak more about IVF now, it feels like there's still like people underestimate the emotional as well as the financial cost of IVF. And we know people, I know people, and things like that. That is a thing, isn't it? People underestimate I think sometimes it gets normalised, IVF, to a certain degree. It's like, oh, do you know what? It's just a process. It works or it doesn't. But we underestimate that emotional sense.
And I think the point that you make about the sort of generation of parents becoming older feels like that's just a continuing trend. I have 2 little girls, lucky enough not to experience, significant fertility challenges. But, I had my girls at 36 and 39. So, you talk about this, cliff edge at 35, that was a real consideration, definitely for me. But equally, I think life continues in certain journeys. I look at my story, and I was pursuing a career and met my husband later, and all of these reasons that mean that this sort of further down the sort of life experience of having children feels like that's a continuous trend, really. So I think it's really interesting because, I think actually the older you get, my experience is the more people that who have experienced or are experiencing IVF. And I would say that it comes as a surprise, the physical and emotional toll that takes.
Yeah. And I think, Jordan, when we were speaking before we started kind of recording and things, there's this imbalance between people talking about failure and success with IVF, isn't it? You don't hear about the failure as much. There's still this taboo, with like miscarriages and things. It feels like it's getting better, but I don't know whether that's just because of the rise of social media, but there still feels like an imbalance there.
Yeah, I think it's one of the few remaining major health stigma that exists. I think part of that is because I don't think we as a society appreciate just how common it is. 1 in 6 couples will face infertility. I don't think that is well appreciated. I think the second component is it's very personal. It's the first time an individual or a couple will confront their bodies or systems failing them. By the time you hit 60, 70, you have a lot of friends who might have issues with their hip or their heart or their eyesight, and your body failing you is no longer seen as a personal failure. I think when you're young, and young by all accounts, and you don't know that your friends might be going through a similar journey, or that society might be seeing people at similar age going through that sort of journey, and you see yourself, going through these difficult fertility journeys, often at extreme cost, with unknown explanation and no clear way to fix it, that can feel like a really serious personal failure that then you try to like close off and focus on yourself. And it's not often until you have a successful outcome that you might then disclose, actually we had to go through IVF, or we went through other services to help get pregnant. If you're not successful, actually it's quite a difficult subject to broach publicly. And frankly, if in patients' own right, they may not want to expose their personal life in that way in a broader setting. So I think it is changing. I think certainly as more and more people go through these journeys, those conversations among peer groups are happening more often. But I would certainly say we're not close to it being a subject that society is willing to tackle sort of head on.
I think that point that you make there on failure that's resonated really with me, because again, the people that I know who have experienced multiple cycles of IVF, typically they are people my age, so older, late 20s, early 40s. There is that, what else in life can you invest so much in, financially, emotionally, and no one can actually say you're going to get what you want out of it. You know, there is still this very realistic outcome that it may not be successful. And so I think, that failure piece definitely really resonates with me.
Yeah.
Is there a case that, I'm sure through the journey of building U-Ploid, you spoke to countless patients who've gone through IVF. Is there a feeling that they feel like unsupported in this journey?
I don't know that I've come across the unsupportive angle. In fact, I would say that clinics have do a very, very good job of, certainly in my encounters with clinics and with patients who speak, do a very good job of providing additional support and counselling around the fertility services. However, I will say when we do speak with patients, and patients reach out to us all the time, when I kind of hear what we're doing, maybe that's slight bias in what I'm about to say, but they tend to be very, very well informed. Like they do their homework, they run down every forum, every website, every textbook to understand everything that there is around the field, and therefore what might their options look like, and where might certain clinics offer certain treatments or add-ons that they may or may not be aware of that may or may not have any effect on fertility at all. But I would say certainly on the support piece, I don't know that they necessarily feel unsupported, but the very fact they have to go through this on their own, maybe with their partner, creates this kind of high tension environment. And we know that infertility journeys are a big driver of divorce. We know this is the case. And I guess when you put that kind of pressure just on a couple, they might be going through all other things in their life, their career, maybe they've got a house, all the other stresses of life. That they're trying to navigate, and you lay this on top, not just the financial angle, but the psychological and emotional, then you need a village to support that kind of system. We just don't have a society, I think, that's ready to go there.
Yeah, like you say, the journey for IVF starts long before you visit a clinic or even start those conversations. I want to spend just a little bit of time on, why does like reproductive health feel like under innovated? Why does it feel like the poor therapeutic area child compared to other areas? So why do you feel it's attracted like less innovation compared to
it has no prestige. It is the unloved therapeutic area, and there's probably a few reasons why. Probably two big ones. Until relatively recently, fertility was a niche market. You go back 30 years ago, total number of annual IVF cycles were few and in very select markets. And these were markets often where you're offering treatments to younger patients on average, certainly younger than today. And so the scope for improvement, as well as the market for improvement, was small. When you compare that maybe to other opportunities that investors or companies might spend their time on, oncology, cardiovascular disease, immunology, or other rare diseases that might have a greater appeal because of how serious the outcomes might be on life and death. But reproductive has never had that moment, never had the aha moment. It's also never really had a breakthrough commercial moment where, with obesity, you had the very first GLP-1. It's not a new drug. It's been around for 2 decades. But we had this big moment where, okay, actually, it turns out you can launch these products and there is a return on an investment, and therefore I'm going to invest in research in obesity. You never had that moment in fertility. So you haven't necessarily seen people switch on and say, I want to invest in reproductive health. That's the area I'm really excited about. I think the second challenge really comes back to what we were saying earlier in terms of the personal, where you look at what's happening in clinics, with patients who go through this journey relatively on their own, and therefore that stigma that surrounds it. People just do not appreciate how big a problem this is. So you've got the societal somewhat ignorance due to stigma. You've got all of the clinics tend to be private companies.
Yeah.
So there's not very good public data on, what does their usage of expansion look like? What does their patient counts look like? And then many of the pharma companies that do sell drugs for like hormone stimulation are also private companies. So if you're a public equities investor in life sciences, these are not companies you're spending time looking at or getting a sense of, what does demand for these services look like? And I think when you pair those two things together, you're not seeing the same amount of money flow in to the space, which means you're not attracting the talent that other sectors might easily attract. And that kind of leads to this kind of paucity of innovation that we've seen over the past 3 decades, where we've kind of just stagnated at where we were in the 90s.
Is that global as well? Obviously, we operate across the US as well as Europe. Does it feel the same like both sides of the Atlantic?
I think so, certainly in reproductive health. I mean, there are very few programs. When I first actually got interested in fertility, my ambition was to join a fertility biotech. I was of the view that this is where the wave is going. There must be so many companies looking to solve this. No, there wasn't. You count on one hand, certainly clinical stage. You had Gamito out in the United States. You have this company out in Japan, Dioceve, early stage program. Out on the West Coast, you've got Conception, and you've got a whole bunch of device companies. And then lots of apps and lots of AI and the rest of it. But in terms of actual therapeutic innovation, paucity. And I think it comes back to the same 2 reasons. Ultimately, capital is global, talent is increasingly global, and they haven't been channeled towards reproductive health in the same way that maybe other therapeutic areas have been able to do the same. That said, there are pockets. So Vietnam, for example, is a place where you are seeing really extreme innovation in IVF in all kinds of new modalities.
Really?
Yeah, it really is. I don't know the reason why. I actually don't know the reason why, but they do really specialized retrievals, really specialized IVM. It's really commonplace there in a way that it's just not anywhere else in the world. But yeah, a bit of an oddity, but yeah, generally speaking, no.
I think it is also the crudity of the prognosis and the outcomes as well, isn't it? Is that you referenced it a little bit before, this sort of risk of death caveat, whereas there isn't an immediate connection between infertility and experiencing infertility and risk of death, albeit we know the emotional toll and the physical toll. So I think that impacts things as well.
Yeah.
Just even from an emotive perspective, there is the commercial side, but I think from an emotive perspective as well.
Public and private. I mean, very few governments will pay for IVF. I mean, in the UK, 1 in 4, 1 in 5 cycles are paid for publicly. That number declines every few years, which is eroding down. It's mostly out of pocket.
Yeah.
Insurers don't really like it.
No.
Outcomes are so poor that, what are you really paying for? It's like 3 rolls of the dice, 4 rolls of the dice. What, at the end of how are we going to appraise the value? How are we going to appraise the value of the investment? And so you've got this kind of rise of these they brand themselves as insurers, but they're really just very large credit vehicles that will borrow big credit facilities and then lend against that to individuals, who then load them with a lot of debt, makes it more accessible perhaps, but then you've got the longer tail problem, especially if you end the journey with no baby, which 7 in 10 couples do. So it's I think on both sides. I think politically, I think to your point, very few countries can justify spending taxpayers' money on something that doesn't feel deadly in healthcare.
Yes,
There are exceptions. So Sweden just announced up to 6 cycles fully covered by the government.
Really?
That's an example of in the Middle East, they do quite similar. They invest publicly in this. But generally speaking, governments are nervous about that kind of expenditure for that exact reason.
It's a real paradox, isn't it, with the patients who are willing to spend huge relative sums of money to out-of-pocket spending on that. How does that payment model shape that patient experience as well? Because this is a extremely significant.
It's extremely cost. I mean, maybe I say a separate story. When I was growing up, and you watch all these game shows on TV, and they win this prize money, it was consistently reasons for being on the show was want to buy a house, want to pay for my wedding, want to go on holiday. The classic. There's not a game show I watch these days where at least not one of the contestants are saying, I want to pay for IVF.
Yeah, true.
And again, it's not paying for a baby, it's I want to roll the dice.
Yeah.
And again, if particularly on advanced reproductive age, it really is roll the dice with very poor outcomes.
Yeah.
But in terms of what that looks like personally, in terms of what that looks like from a patient, it can cost easily 5 figures. In the United States, much more. You can get $20,000, $30,000 per cycle. In the UK, maybe you're getting around $10,000 per cycle. And that's money you've got to save, find, beg, borrow, steal, however you're going to get that money to pay per cycle. And then again, And then again, each time you're putting this money and hope and dreams into a cycle for which you have absolutely no guarantee that it's going to get there. In the UK, what do we have? Last year, about 80,000 IVF cycles.
Wow.
It grows globally. We have 5 million cycles in the markets where we can actually capture those data per year, growing exponentially. And all of it out of pocket, because it's something that people really want to do. They're willing to commit everything to it. They do so in lieu of maybe a house deposit, do so in lieu of a holiday, in lieu of other parts of their life they might have spent that money. And they're in this difficult spot. I mentioned earlier that we are seeing increased access through companies that notionally brand themselves as insurers, but in truth are only debt vehicles. And that's a separate, I think, bubble that's going to emerge over the next decade, where we talk about student debt, we talk about other forms of consumer debt. I think IVF debt is just a bubble that's growing, that more and more couples are going to find themselves on the hook for, which will be especially painful for those who didn't end up with a child on the other side.
Yeah. There's an element that feels very like Black Mirror documentary about the world it goes down, isn't it? You spoke about probably the base level cost, but increasingly now, there is additional bolt-ons to IVF treatment, isn't there, in terms of, the colour of hair, the type, which sounds really like basic to say, type of baby you may want to have, and it just gets increasingly more complicated and just adds more stress to that decision making, isn't it?
Yeah.
I think before we spoke, Hannah, it's that very nature potentially of certainly in the US, where you have a shopping list of treatments. I think one of your stories before, when we were kind of preparing for the show, was like going to when you lived in the US and you kind of sprained your ankle, and they would give you a list of, well, what do you want to do?
Yeah.
just an ice pack's fine.
Yeah. Yes. Yeah. Yeah. An X-ray, please. Yeah.
Cool. Let's speak about U-Ploid. It makes sense kind of whilst you're here and what you're building. Levanta is the headline for U-Ploid. So just explain a bit about the science behind what you're trying to achieve and increase those outcomes.
Yeah, so we spoke at the beginning about age being a really important risk factor for infertility. And that's especially true for female reproductive age, because obviously eggs are by far the oldest cell in a woman's body. That's stark contrast to men. You do see declining fertility in men, both with age, but also increasingly just with the times. Men at 30, men at 40, men at 50 are a lot less fertile than their peers 20, 30 years ago. We know that. We don't really know why. There's lots of factors likely at play there. But in female reproductive age, it's mostly a decline which is a function of the age of the cell itself. Because eggs are produced in the fetus, and they've got to survive decades before they may ever be used. And one of the things that goes wrong in these older cells is that their ability to prepare for fertilization is compromised. And what I mean by that, so every cell in the body, including the egg cell, will have DNA from mother and father. Every cell. But before that egg can be fertilized, it needs to discard half of its DNA to make room for the sperm's contribution so that the baby has a whole new composition.
Wow.
The problem is that separation happens once every ovulatory cycle in the eggs that will enter the maturation phase. And those eggs do that separation incorrectly with exponentially increasing propensity with age. So by 33, roughly half of eggs will make an error. By early 40s, it's north of 95%. So it's a very, very steep decline in outcomes. Now, that's not necessarily a problem because you can try and try again. It's literally a roll of the dice. But then particularly when you look at north of 37, 8, 9, north of 40, you're talking a lot of potential ovulatory cycles before you might have a shot on target. And so when we think about what the problem is, it's like, well, okay, well, how do we solve for that? Option one is you just do lots of cycles. For reasons discussed, that's not financially possible, let alone physically, emotionally, and psychologically. Anyone would want to do that.
Yeah, it doesn't feel like a fair suggestion for the individual experiencing it.
The second option is a time machine, also impractical. At the end of the day, when people talk about fertility preservation, what they talk about is egg freezing. Egg freezing only works if you freeze eggs and when they're at their peak function. Okay, in the UK, median age at which someone will freeze their eggs is 38. That partly reflects, I think, education gap. I think it also partly reflects that when people are going through these journeys, there's a realization that 38 is better than 39, 39 is better than 40. If I don't freeze now, future cycles are going to be dependent on eggs that have a higher risk of error. So that's the problem. What we're trying to do at U-Ploid is develop systems to prevent those errors in these eggs and ensure that every egg can correctly segregate their chromosomes, correctly separate their DNA, and you have fertilizable eggs that will blast into embryos and transfer and develop into healthy babies. Number one cause of IVF failure is this chromosome problem. It's called aneuploidy. Number one cause of first trimester miscarriages are caused by this problem, aneuploidy. And so if you can treat that issue, then you treat all the downstream suffering and misery that comes from repeated IVF cycles, repeated attempts to get pregnant, repeated miscarriages, which itself is its own serious health indication and consideration that I don't think we take half or anywhere near as seriously enough, not just the psychological, but the physical risks that come with that. And so that's what we're developing with Livanta. It's our lead from our platform that we've developed specifically to improve the rate at which they separate faithfully, as it were, ensure that the eggs are healthy and ready for fertilization.
And how's it going?
So far, so good.
Yeah.
I can tell you it works in mice, but of course, lots of things work in mice. And so we have a very large ongoing human study here in the UK and in the US where we are evaluating for the first time whether we can translate what we've seen in mice, which was a near eradication of this error in older eggs, to a human. And so I can't say too much yet, but I will be able to say more later this year on how that's going.
And how does it fit into like the existing clinical kind of like the workflows at the moment? How will Livanta fit into it?
So we're working very closely with clinics on this at the moment. And we actually have a dedicated study in San Diego looking exactly at this, because it's all very well and good generating new technologies, but if it's not going to be practically applicable into an IVF setting, it's never going to be used. And if it is used, it's going to be used in very niche settings. So what we're working with the clinics out there with and continue to iterate on are ways to inject this into oocytes using existing equipment. So every lab we fitted with something called an ICSI rig. And this they use, it's like a microscope with little needles that you would use to inject sperm into eggs. In some forms of male infertility where you might have issues with motility in the sperm, you can inject the sperm directly. Well, actually, we're thinking, what if we could repurpose this equipment and use it, instead of injecting sperm, to inject Livanta? And so far, that modality is working quite nicely and something we'll continue to iterate on and build on. But actually, if we're able to use existing equipment, then all of a sudden, the embryologists don't require any new training per se, and the clinics don't have to invest in any new equipment. And this should make, in a world where this is available to clinics, which it's not yet, in that future version of reality, then actually it might be something that clinics all over the world might be able to adopt and offer their patients if appropriate.
I want to dive into broaden this up now and speak about like the founder story. See, Hannah, we can bring in your story with Meet here and the realities, beyond the science of trying to grow a really purposeful company, the challenges and everything behind it. How did your story start?
My story, as I said, it was a bit of an accident. I ended up in a rabbit hole on this project looking at fertility, and the further I went down, the more perplexed I was that there wasn't more innovation happening and there wasn't more opportunities for people to get involved in this space. And I came across two brilliant scientists who since became my co-founders at U-Ploid, Alex and Chloe, who felt very similarly, but unlike me, had spent their careers working dedicated on fertility and in egg biology research, and had lots of hypotheses about things we might be able to do that could potentially correct this error. And I was just taken away. I was blown away by both the mission, the vision, and the technical capabilities that they had. That, a little over 2 years ago, we jumped in full time and have been kind of building ever since. And we've gone from pure hypothesis-driven ideas around how we might treat these errors through to a platform of candidates, and now our lead candidate in human testing. So it's been a bit of a roller coaster for me personally, because, as I say, I'm not from this space at all. And so it's been a very steep educational curve. But then the first time I'm building a company, so it's been a very steep founder journey. Like, what does it mean to build a company? You've got all of the stuff that maybe seem obvious about building a biotech, and then all of the operational stuff that comes alongside that you have to think about. And how do you build the team, and how do you build the culture, and how do you choose where you're going to build, and how do you choose the right partner? How do you choose the right investors? And it's like no 2 days are the same. And
it truly is that analogy of building the plane while you're flying it, isn't it? You know, there isn't time on a journey like that to sit back and be hugely theoretical. You have to learn as you go.
Completely. But when you're building the plane, there's no blueprint.
No.
Because it hasn't been done yet. And so then you're figuring out, okay, well, what can I learn from things that have been done before? What might be applicable, and what might I have to do differently than what's been done before? And there's very difficult to even appraise that, certainly on any short time horizon. So you're constantly iterating, and you have endless self-doubt as to whether this is the right approach, because you won't find out for many years. And so you take a bit of a bet in this direction or another. You've hired someone who was great in the process, is it actually going to work out? Is it all going to play the right way? You don't know these things going in, and so I've thoroughly enjoyed the experience so far. But it's no 2 days are the same.
I think Hannah will be able to say, not to be daunting, but Hannah can probably say it doesn't stop even after 15 years.
Goodness, yes, yeah, very different. I think that's the thing that, as a founder, as a chief exec, as a leader of a business that has multiple different facets and service lines, that's the bit that I think keeps people like us engaged, which is no 2 days are ever the same, but comes with its challenges too.
Obviously something specific, and you again, something that you've both been involved in terms of investment slash raising capital. Jordan, how's that challenge been, working in that world of trying to get cash into the business to realise, your dream and your vision type thing for U-Ploid?
Mixed. I'd say mixed. In many ways, it's been relatively easy to raise money in that people like fertility. People generally at the moment understand that there's unmet need. They understand the problem. Certainly when you explain it, they kind of understand that. The challenge in biotech, though, is you're so far away from revenue, and they're taking really long bets on teams that are untested, and long bets in assets that are untested. And so I think you've got to kind of find the right capital partner, and I really mean partner, because they're going to be on this with you a long time before something may bear fruit. And so I think certainly one of the things I've learned in the last just 2 years, I guess, in working with certainly our investors and potentially ones that might join in coming years, is thinking about, do they share the risk appetite that I have? Do they share the vision of what we're trying to build, or they're going to get cold feet and have different views, fast forward a couple of years? And do they share the view of how the world is changing, and therefore what actually we need to be doing and thinking about to build the business we want, not just next year, not just for Livanta, but for 5-10 years from now, when we think about what does it mean to be the leading reproductive health biotech globally. Certainly that's the vision and the goal when we look for investors. But no, it's certainly not easy. And I think certainly when you're competing against AI, or you're competing against the litany of other amazing things that are happening right now.
That only took 35 minutes to mention AI. I think that's pretty good for a podcast nowadays.
I do. Yeah, I think that's absolutely correct on the investor capital partner piece. It's finding that balance between understanding that individual or institution is investing in for a positive outcome, and you have to call a spade in that regard, but at the same time have that confidence that they'll have the patience to go on the journey with you, because in a biotech or in a services business like ours, it's not a click your fingers and it will all happen. No. You have to take the steps and go through the processes and the journey to be able to build that value. So that definitely resonates with me.
Is there anything you would have changed in your approach over the past 2 years?
Everything, I think. It's. I think there's one benefit I would say of being a founder of a small company is the ability to iterate and change. In that the feedback loops on some things you do can be really short. There's not committees you have to go through. You have a meeting, you make a decision, you commit to it, and you find out whether that works or not. And certainly, I think the steepest learning curve, I would say, is in partnerships. So working with both vendors across the business, working with clinics, working with patient advocacy groups and advocacy groups more broadly globally, has been instrumental. We've had great experiences and poor experiences, but I think part of our model and what we've really been able to do quickly, in part being a small company, is just iterate. If it's not working, there's no point both of us continuing on the path. If it is working, let's double down, let's go further. And so I don't know that that answers your question, but certainly I think we've definitely made a lot of mistakes along the way, and if we were to do it again, knowing what we know now, we probably made those.
It's that whole thing, is hindsight is a wonderful thing, isn't it? But you don't have that, when you're making these decisions. It is that, fail fast and change the path when you need to. But yeah, I think I have a complex relationship with hindsight thinking, because you only ever have it when you've moved through something that you've learnt from. So.
You mentioned that kind of moving quickly. In your world, how do you balance that? Obviously, that like scientific rigor, if you like, with that ability to move quickly. That must be quite a challenge to do.
It is, and maybe even more challenging for our science and R&D team, because we have one big advantage in that everyone at the company, certainly on the science side, has been working in the space for a decade plus. Alex, our chief scientific officer, 2 decades been in this space. And what that means is that we tend not to make many mistakes in the lab, and we tend to have like a very clear plan of what we want to do. The scientific plan is very clear, and that ensures that we can move comparatively quickly, both in development of new assets, but also evaluation of those assets in our animal models. So on that side, we've been very fortunate. But of course, when you're building a science company that has lots of other things to worry about more than just necessarily what's happening in the lab, then that tension constantly builds, and you have to think about, okay, well, when do we need to pause the science to focus on other things? When does the science need to move twice as fast to keep up with other things that are happening? And so that tension is constantly happening. I don't know that I have the answer for how you do that, but certainly
I don't think there is an answer. That's the sort of secret sauce of building a biotech business, is being able to answer the science and the commercial decision making at the same time. Yeah.
And I think with the commercial decision making, if I put my marketing hat on as well, is that you're operating, as we've discussed, in a very emotive part of life sciences where, you don't want to hype too much about stuff, but you want to give hope. And equally, it's an emotive subject. It's a political subject in a lot of places as well. It's a lot of things to think about.
Reproduction is the central component of any species' existence, certainly our existence in de facto political, and de facto there's ethical considerations, and de facto it's a very personal story. I think on the hype piece, it's something we're acutely aware of, and we want to straddle that sufficiently exciting a company that we can attract investment and top tier talent and all the rest of it. But we do not ever want to be letting the claims exceed what the data shows, and we will always be data led. Particularly in reproductive health, there have been countless examples of the past 2 decades where companies have gone too far. They promised too much. They've
hope,
and hope. It can be devastating, and it can lead companies to make mistakes that they would not otherwise make unless they feel they've got to live up to something that's not true. And so for us, we're moving very quickly, certainly, and that's something we're very proud of. But at no point do we ever want to find ourselves in a situation where what we're saying is exceeding what the data shows. That might be frustrating, I think, sometimes for patients and certainly for clinics, but at the same time, there's no other way to do this.
Yeah.
Hannah, any advice to Jordan as a 15-year founder to a 2-year?
Very, very different. Yeah. I mean, obviously, I say obviously, but our journey was that we were private as an organisation until we took private equity investment in 21. So my experience of sort of entering, that deal world was through the private equity lens, and we've had a really good experience with our investor. But it does come back to what we said before: is when I executed our MBO, I was lucky enough that it was a really competitive process. And the result of that competitive process meant that I had a real choice to think about who the best partner for me and this business was for the future, as opposed to necessarily for the valuation at that period of time. So, that's what I think is, it's not always possible, but I do think that if you can preserve that confidence of who you're aligned with, then I think you're much likely to get better outcomes and experientially be able to continue the growth of the business, working with like-minded people with similar views on the world and what the opportunity is. So
yeah, just it would be remiss, Jordan, for me not to talk about kind of talent, people, and your team. Obviously, you spoke. I think you didn't mention it here, but you kind of the U-Ploid journey started as three of you in a pub.
Yes.
I believe.
What the best things do, don't they?
Yeah, they probably do. And then, but kind of what is that plan? Like, what's important to you with a team as you grow? To cultures change. You can't keep culture. You can't, keep hiring the same type of people. And you mentioned the operational structure about it, but what's kind of your vision for the team and growing the team and the people, the type of people and everything like that?
Yeah, well, we're still a lean operation. We're 8 people. I think we like being lean because it avoids some of the communication taxes that come with getting too big, particularly if the number of people involved in decisions exceed the number of perspectives you necessarily need. I think if you trust people in their domains, then actually they should be able to run. And if they make a mistake, that's not a problem. We can iterate and we go again. That said, the company is going to undergo a lot of changes in the next 5 years when we go from preclinical to clinical, and we go from clinical to commercial. Those are 3 very different organizations that require 3 different organizations, different people, and different governance. And so when we think about that journey over the next 5 years, actually it's about, okay, well, how can we get maybe 2 years ahead, have a view of where we need to be, who are the people we need to build relationships with? Because we don't have the advantage of being an oncology company that people are just naturally going to be very excited and confident about. We know we're always in pitch mode, because when you hear reproductive health, you're like, oh, it's a little bit of a weird one, a little bit fringe, a little bit niche. So it's building those relationships early, finding people who are genuinely interested in doing something new and different, bringing their experiences from other therapeutic areas, and then doing so in the correct sequence way. We bring people in at the time when we need to make those decisions. We can trust them to make them and give them that independence, but it's about doing that in a lockstep way. And I can't say that we've got necessarily a big track record of doing that. As I say, we're just 8 people, but that's certainly our view and what we want to achieve for the next kind of 5-10 years.
I think it's the fact that you're thinking about it. I'd suggest from experience shows that you're probably quite far ahead than some. Obviously, we have the privilege, don't we, Hannah, of working with all different types of biotechs, and the ones that succeed, grow quickly, are the ones who are thinking ahead. They're doing the planning, they're building the talent pool and people who are interested that they might not be able to join now, but they're involved in the company and stuff, aren't we? That's what we see a lot.
It's interesting. We talked about before about this, how do you blend the science with the commercial side of things as well? But I think the thing that I probably missed out of that is that organizational design stroke talent focus, because we know that in our industry the outcomes are as good as the people who work within the organizations to be able to build them to the market. So I think we do see in a lot of our organization huge amounts of science, the organizations we partner with, huge amounts of scientific expertise, increasingly more understanding from a fiscal, commercial perspective. But sometimes the thing that is missing is actually thinking about, but how do we create an organizational design which maximizes people's potential, that creates clarity over decision making, that allows the right structures to be in place so that an organization feels entrepreneurial and progressive, but equally you're going to create a culture and a talent environment where people feel engaged, committed, and willing to produce those outcomes. So I think that's definitely the third part of it. And we do a lot of advisory work in that regard, which is using our experience of talent and organizational design and people capability and overlaying that with that sort of scientific and commercial importance of decision making.
I think it's having that like that humbleness, isn't it, from a founder entrepreneurial point of view. Sometimes it's easy to think, I've got to go this way, this is the way we're doing it, but a lot of the businesses who we do see succeeding like very well are the ones that just, you know what, we don't know the best way to interview for this type of role. Can you help us out? And it seems very basic, but it's not.
Values,
Yeah.
mapping out values and creating what is the DNA, excuse the pun, that's going to connect, people within the organization. And how do we think about competencies, and how do we assess competencies when somebody has got, you referenced before, people that you work with that are way more expert than you. I have people in my business who are way more expert than me in terms of that sort of particular area, but you still need to be able to assess competencies outside of that expertise. So I think that's, values, competencies, they're the things that, often we find in organizations who are either going into or in high growth phases. They kind of get to the bottom of the list, and often they're the ones that allow that ability to be able to move at pace. And that's, again, what the aim of the game is, isn't it?
Well, really looking forward to see the U-Ploid journey. I just wanted to kind of tie the conversation up, really talking broadly about what we hope to see, like the future of IVF, and really what do you feel would make IVF feel as a modern therapeutic area, not one that's stuck in the past? What would that look like in reality, in your view?
I think outcomes have to improve. I think if we measure any other therapeutic area, whether like 5-year survival rates in cancer, whether you look at like remission rates in autoimmune conditions, whether you think about weight in these new obesity drugs, like fundamentally, if you want to see a better IVF, we need to be improving outcomes, and we need to have a really clear focus. Part of the problem in fertility is we don't have good consensus on the outcomes we care about. Clinics and researchers use different measures to measure different components, which can be confusing for patients, first of all, but also means from a research community, it's very difficult to align on what we're trying to resolve for. And at the end of the day, what we're really trying to resolve for is cost and time to baby. That's really it. Whether it's who's paying for it, whether it's an insurer or a public payer or an individual, those are the variables that matter more than anything else. If we can get to a one cycle, one baby world, independent of alternative risk factors, that will be the dream. That is where I think we reached phenomenal part of the spectrum, but we are sadly very far away from that.
I think everything you said, it is, and I know obviously U-Ploid and your focus is in this sort of older generation of parents, and I think that's the point for me, the stigma associated to that as well, because I mean, even I was in both of my pregnancies a geriatric mother.
Yeah, I know.
It's
like 2026.
They still call old people geriatric anymore, so it seems absolutely wild that the geriatric term is reserved for mothers. So, and I think there is a stigma associated to that. So I think in the work that you're doing, and maybe it is as a geriatric mother, it's particularly totally focusing on that outcomes of this population of people, because actually I think what I found really interesting about your business and learning more about it is that there is such a stark difference between younger people who are looking to conceive and older people, and the data points are so different that actually sometimes when you see them together it feels slightly disingenuous, I think, doesn't it? Whereas actually when you pull those data points apart, then I think it really the outcomes that you're talking about there will start to become much more meaningful, I think.
Yeah. Where does that responsibility for that education piece lie, really? Is it from government level all the way down?
I think about this a lot. I don't know. I don't know where you can apply the accountability for education, but for sure there is a big education gap. The number of people I speak to who seem to be under the impression that if they can't have kids naturally, there's always IVF is astonishing.
It's just a myth that needs...
It's a complete myth, because 7 in 10 couples who start a journey end it without a baby. I mean, it's shockingly bad in terms of a backup plan, but it's the only backup plan we have, particularly in advanced reproductive age. And then you have the another myth where people who don't seem to connect the dots between egg freezing and IVF. Now, if you freeze your eggs and you rely on those, it's going to lead down an IVF journey. Okay, you don't have to go through necessarily the same stimulation protocol, but it's still, all the rest of it.
Preclude,
It's the exact same locked-in journey. Or when we think about actually where is the value in freezing eggs, We know that the best outcomes, really under 33, you get the absolutely the best outcomes. And yet the distribution curve not only is north of 35, it's drifting up every year. And that's not just true in the UK, that's true globally. And this sort of education gap has a serious consequence for parents and couples deciding how and when they want to have kids. Because you can plan for this, you can make decisions that might mitigate against some of the downside risks of poor outcomes in this age group and in this procedure. But you have to know in advance to be able to make those decisions.
But equally, when we're talking about the science, it's equally not really good enough to say you have to make a different choice, as opposed to investing in the science to be able to
agreed.
create a different outcome. Because again, I look at my personal circumstance, like I didn't meet my husband until my mid-30s. You know, it simply wouldn't have been the right. I knew that it was the better thing to do, but equally I was pursuing a career and hadn't met the person that I wanted to have a family with. So I think sometimes it's interesting. Absolutely, the education, I think, to a point is there, but it's not always the answer. You know,
very true.
There's like I said, you said before, this lack of investment. It's like, in some ways, I feel it's not okay to say, or do it differently. You know, there should be a scientific underpin, shouldn't it, in a world exactly as you're trying to achieve.
It shouldn't be 2026. Yes, situation.
Absolutely. Yeah.
We need to find that aha moment for IVF, like other places, and hopefully it happens, unexpectedly, and like we all get those, what everyone wants, better outcomes for patients. So, Jordan, that was a brilliant conversation. Thanks so much for joining, and thank you as always. We look really forward to like following the U-Ploid journey over the coming months and years, and hopefully you achieve everything. So thank you very much. Cool.
Thanks for having me.